and we will move forward with our pathology or biopsy conference. Dr. Nicosia, if you want to get us going. I think you're still muted.
Good morning.
Good morning.
So the case I'll present is an outside case. We received this biopsy from the Carson Tahoe Health System in Carson City, Nevada. Unfortunately, the nephrologist was unable to attend, but I have some limited clinical information I think will be sufficient for this short presentation. So I'm going to share my screen. And let me know if you can see it.
Yes, we can see the screen, but it's in yes, there you go. That's perfect.
Perfect. Okay, so let me just go back. All right. So the patient I'm presenting is a 64-year-old female. As I said, I have limited clinical information, but I think it's sufficient. We received this clinical history. The patient presented with chronic kidney disease, and the elevated serum creatinine was first detected 3 years ago. Proteinuria and hypertension. The serum creatinine at the time of the biopsy was 2.1. Patient has 3+ proteinuria and very rare RBCs and WBCs in the urinary sediment. So this is a representative view, low-power view of the biopsy. We had many glomeruli. Some were sclerosed. We counted we estimated approximately 46% of the glomeruli were sclerosed. The remaining glomeruli had some pathologic abnormalities, which I'll show you. But at low power, what was striking was the presence of these patchy areas of cellular infiltrates in a background of tubular atrophy and interstitial fibrosis. And here is a slightly higher magnification view that demonstrates the presence of these cellular infiltrates and tubular atrophy. Some of the tubules also show features of injury. And you can see even at this magnification, the patent glomeruli are not normal. The mesangial areas are slightly expanded, and here I can show you 5 representative glomeruli that demonstrate the segmental expansion of the mesangium due to increase in extracellular material and cells. In some areas, there is reduced staining for the joints, the silver staining, so we call reduced argyrophilia. Some of the capillary loops are partially obliterated by circulating nucleated cells or swollen endothelial cells. Some of the capillary loops have an expanded subendothelial space, and there may be even some segmental thickening and duplication of the basement membranes. And rarely we saw glomeruli look like this, which suggested the late stage of a segmental sclerosis scarring process. Here is a higher magnification view of one of the glomeruli. It's slightly distorted at the edge of the biopsy, but you can see how some of the capillary loops are partially obliterated by cells, and here this can be even swollen endothelial cells. And again, there's some segmental thickening of the capillary walls. But let's look at the interstitial cellular infiltrates, which were the highlight of this biopsy. As you can see, these infiltrates are pleomorphic, and there are some peculiar looking cells. Some of the cells, like this cluster here, for example, have fairly prominent, large, round nuclei with very fine chromatin and prominent nucleoli. And then there are cells that are eosinophilic, but with small hyperchromatic nuclei. Here's another view of these cells that form clusters. And some of them have hyperchromatic nuclei surrounded by a ring of eosinophilic non-granular cytoplasm. Here is another view of the cellular infiltrate, again, clusters of fairly immature looking cells with the round nuclei. In some of them, you can even see perhaps some nucleoli. And also eosinophilic cells again. And some of the cells have an amphophilic cytoplasm and slightly indented, at times kind of horseshoe-shaped or bean-shaped nuclei. And some have nuclei that are multi-lobed. Another view of a cluster of immature-looking cells with, again, round nuclei with multiple nucleoli. But also now we're seeing what look like eosinophils, so cells with eosinophilic, but also granular cytoplasm. In addition, we found focally bizarre-looking large cells with multi-lobed nuclei in a background of a pleomorphic cellular infiltrate, which included also neutrophils and eosinophils, and occasionally also cells with dark hyperchromatic nuclei surrounded by a ring of eosinophilic non-granular cytoplasm. The immunofluorescence, interestingly, showed almost no staining of the glomeruli except for some weak mesangial staining for IgM and no IgG staining. However, the IgG staining highlighted nicely the tubular basement membranes with a granular to pseudolinear pattern. And we could see the same pattern in section stain for kappa or lambda light chains. And also for C3, even though the C3 staining was somewhat weaker than the IgG staining. So there is immune complex deposition in the tubular basement membranes, but no obvious immune complex deposition in the glomeruli. So with this constellation of findings, what would be the differential diagnosis? Any thoughts, suggestions? Any volunteers? Well, I can tell you what my differential diagnosis was when I first saw it. It included, of course, at low power, the main concern was interstitial nephritis. But then as I look at high magnification, I had other thoughts in mind. And before I share my thoughts, I just want to tell you that I called the doctor and he informed us that the patient had a prior history of myelofibrosis, which had been treated with bone marrow stem cell transplantation in 2013 and 2015, twice. So perhaps the first attempt at bone marrow stem cell transplantation was unsuccessful. It was repeated again. So essentially, 10 to 12 years ago, the patient received a bone marrow stem cell transplant for the myelofibrosis. At that point, I felt that because of my suspected diagnosis, I felt it would be a good idea to consult my good friend and excellent hematopathologist, David Dong, at the VA hospital. So together we reviewed the slides, and he kind of confirmed my suspicion and recommended that I stain the sections with the following markers: CD61, icadirin, CD34, and myeloperoxidase. And the next slide will show you the result. I'll show you in the next slide. I'll show you the results and what the diagnosis is. Icadirin, as you probably know, is a marker of epithelial cell differentiation, but in the bone marrow field, the bone marrow pathology field is used to highlight, demonstrate specifically immature erythroid elements. So it stains erythroblasts. So the icadirin staining nicely demonstrated that those immature cells with round nuclei and the prominent nucleoli arranged in clusters were erythroblasts. The CD34 staining is a marker of endothelial cells, and in fact, you can see nicely the vasculature of the kidney biopsy demonstrated with the CD34 staining, but it's also a marker of myeloblasts. And if we had seen a strong staining for CD34 in many of those immature cells, we would have been obviously concerned for involvement of the kidney biopsy by acute myeloblastic leukemia or a myeloblastic sarcoma. Unfortunately, in this case, the CD34 staining was essentially negative with this beautiful positive internal control. Myeloperoxidase is a staining that highlights myeloid cells, and we could demonstrate numerous myeloid cells, including cells with round single nuclei in the infiltrates, which were probably representing different stages of myeloid cell differentiation. And finally, we found clusters of CD61 positive cells. CD61 is a marker of the megakaryocyte differentiation. And here you can see a high magnification view of the CD1 staining that highlights those large multi-lobed cells that I showed you earlier in the H&E staining of the biopsy, strongly positive for CD61. And you can see that these large cells are surrounded by small fragments of cytoplasm, which are platelets shed by the cells in this cellular infiltrate. So with these stains, we were able to demonstrate that the infiltrate comprised trilineage hematopoiesis, indicating that we were dealing with extramedullary hematopoiesis involvement of the kidney biopsy. The other question is what was happening in the glomeruli, because the patient had proteinuria, and by light microscopy, we could demonstrate that there was a glomerulopathy. So the mesangial region here, this is an electron microscopy view of the glomeruli. You can see that this area here, this is the mesangial region. Next to it is a capillary. Right? This is an endothelial cell. You can see that the mesangium shows reduced electron density of the matrix. So there is some electron lucency indicating mesangiolysis. There is also remodeling with increased mesangial cells. And this process is extending to the subendothelial space, which is expanded. And you can see expansion of the subendothelial space also in this capillary loop that is magnified here. And you can see also that in this loop, there is a circulating immature cell with fine chromatin and 2 nucleoli that is partially obliterated the lumen of the capillary. The same feature of detachment of the endothelial cells from the basement membrane, the expansion of the subendothelial space with deposition of new basement membrane material, indicating endothelial injury, is also shown in this capillary loop. Now, in addition to these findings, we had a surprising we made a surprising observation that some of the capillary loops in some of the mesangial areas also contain accumulations of fibrils, very fine fibrils, haphazardly arranged, mostly straight, in this case, accumulating in the subendothelial space of a capillary loop with an expanded subendothelial region. This is an endothelial cell. That's the lumen of the capillary. This is the original basement membrane that is now thickened. And by the way, in the previous slide, I forgot to mention that there is also extensive effacement of the podocyte food processes. So together, all these findings indicate that there is endothelial injury, there is podocyte injury, and there is accumulation of fibrils, which at high magnification measure 6.7 nanometers in thickness, indicating a thickness that would be compatible with amyloid. Is actually in the low range of amyloid, but the congruent staining was negative. And we also performed DNA JB9 staining, which, as you know, DNA JB9 is a marker for fibrillary glomerulonephritis, and that was also negative. In addition, as I said before, the glomeruli were negative for IgG staining by immunofluorescence, and IgG staining, usually smudgy IgG staining of the mesangium and capillary walls, is typically seen in fibrillary glomerulonephritis. So this is not fibrillary glomerulonephritis, and it's not amyloidosis because the congruent staining is negative. These are high magnification view of some of the cell infiltrates, some of the cells in the interstitial cell infiltrate. And you can see a cell like this one that has an indented nucleus with electron-dense granules, most likely representing a neutrophilic metamyelocyte. And the adjacent cell here has these granules with crystalloid structures in them, and this may represent a eosinophil. we didn't see any immature myeloid cells like myeloblasts with our bodies. We only saw cells of this type in the infiltrated by electron microscopy. In addition, we were able to confirm the presence of immune complex deposition into the tubular basement membranes, and the immune complexes by electron microscopy appeared clearly electron dense, and they were thickening of the tubular basement membrane. So this was our final diagnosis, extramedullary hematopoiesis. We gave a descriptive diagnosis for the glomerulopathy, with segmental mesangial expansion and basement membrane duplication, diffuse effacement of podocyte food processes, chronic endothelial injury and segmental accumulation of fibrillary deposits in the capillary walls and mesangium. And there was some FSGS and immune complex deposition in tubular basement membranes. There was also a background of moderate chronic parenchymal and vascular injury. So this is a fairly rare finding, extramedullary hematopoiesis in a kidney biopsy. The largest series has been reported so far is from the Mayo Clinic. They reported 14 kidney biopsies from 14 patients. Patients ranged in age from 47 to 87 years old, more males than females. Like our patient, their patients presented with renal insufficiency and proteinuria. And the most common underlying hematologic condition, like in our patients, was myelofibrosis. And then I had one patient with a myeloproliferative neoplasm, one with essential thrombocytopenia, one with polycythemia vera, and 2 patients with plasma cell myeloma. The histology showed, like in our case, interstitial infiltrates, but they also had cases where the infiltrates were perirenal. And in one case, the extramedullary hematopoiesis formed a mass-like lesion. Interestingly, 3 of the cases they reported had what they described as a fibrillary-like glomerulonephritis. And at that time, there was no DNA JB9 staining, but their immunofluorescence staining was negative for IgG. They only found that in 2 glomeruli, there was some deposition of IgM. In addition, 2 out of 3 of their cases with fibrillary-like glomerulonephritis were negative for Congo red. 1 case was weakly positive. They also had the glomerulopathy they described had features of chronic TMA, like in our case, where we saw endothelial injury, FSGS, and 2 patients had diabetic nephropathy. 9 of their patients were treated with chemotherapy, and 1 was treated with steroids. They had follow-up on 12 patients, 10 of which died from the underlying disease, and 2 patients had persistent chronic kidney disease. None of their patients had a history of bone marrow stem cell transplant. So our case is somewhat unique, and the question remains whether what we are seeing, the extramedullary hematopoiesis we are seeing, is the result of seeding of the kidney by the bone marrow stem cells when the patient was transplanted. And the only follow-up I have is that the patient, unfortunately, after the procedure, decompensated and required dialysis, but I don't have a more recent follow-up. I may get it over the weekend. The doctor promised that he was going to call me, but I haven't heard from him yet. That's it. Any questions?
Wow, thank you for this. I hadn't seen this case before. It must be very rare. Really appreciate it.
Yeah, it's a very, very rare case, and I thought it might be interesting for you to see it and to share the case with the whole group.
There's a comment, looks like in the chat from Charlie Alpers. Maybe the Congo red is a false negative, possibly stained for amyloid P protein.
Oh, that's a good. It's a very good comment. We haven't stained for the P protein, but it's intriguing that if it's a false negative, they also had a false negative when they reported their series. Yeah, but yeah, it's still, it still remains a valid possibility, also given the thickness of the fibrils. We discussed the possibility of doing LCMS with Dr. Smith, but because of the segmental involvement of the glomerular by fibrillary deposits, there may not be enough material to specifically identify the protein using LCMS. And when I was at a recent pathology meeting, I had the opportunity to meet and talk to with the first author of the paper I cited, and they also shared Dr. Smith's feelings that there may not be enough material for LCMS. Oh, there is another comment. Do you think there is utility in getting repeat bone marrow biopsy in this patient? I just don't have an answer for it, but yes, that might be interesting. I don't know what the clinical status of the patient is at the moment. I'll discuss it with the nephrologist when I talk to him next time. Thank you. Okay.
All right.
All right. I will start getting set up with our second case for biopsy conference. All right. Did I do that right? You're seeing the right screen?
Yes.
Great.
Yes.
All right. So I'll be presenting our second biopsy for biopsy conference today, and I'm very happy to have our clinical discussant today, Dr. Lily Zhang. Lily, if you're available.
That.
Looks like they're getting set up.
Oh, okay. One second.
Mhm. Looks like a very fancy conference room setup.
Well, there's lots of support there. We're gonna figure it out, I think. And then I think you guys are muted there in the conference room as well. Alyssa and Danielle usually save me as well with the AV malfunctions.
All right, maybe I'll give them a few minutes. I can start with this background if that doesn't get working soon.
Okay.
There's too many. I know.
Looks like we're on the cusp.
Yeah.
Can you hear me now?
Yes.
Oh, thank you. Thank you for waiting. Sorry, this is our first time doing this all together, so we're figuring we're gonna get through
no
this.
problem.
Okay, so we have a 32-year-old woman who has had a long history of lupus, which is rheumatoid arthritis and systemic lupus, and she's had lupus nephritis class 4, and she presented to our review with oligarchic AKI in March. So brief history, she was initially diagnosed with lupus in 2018, has had many complications from her lupus. Her first lupus nephritis diagnosis was in 2022 when she had creatinine of 0.7 and urine protein creatinine ratio of 1.6 gram per gram. Biopsy at that time showed class 3, up to 8% crescent. and she was really reluctant to go through any active therapy at that time. So she just continued on her MMF, hydroxychloroquine, and pred, and then 2 years later, she presented with kind of more active renal disease with creatinine of 3.6 and urine protein creatinine ratio of 12. And at that time, she went through your plus protocol with cyclophosphamide, and then that led to better control of the disease. So in September, so she finished the Europlus protocol in May, and by September, her creatinine was down to 0.8 and urine protein creatinine ratio decreased to 2.4. And her overall symptoms seemed to be better controlled, and she was maintained on the above therapies plus voclosporin. She couldn't really tolerate the full dose. And in December, there was some evidence that there was more disease activity. Rheumatology kind of reviewed options like changing voclosporin to Tacro or doing belimumab or even enrolling her in CAR T-cell therapy. And patient just kind of wanted to think about it at that time. And then she was admitted in March with marked pancytopenia and AKI, which was consistent with lupus flare. Next slide, please. So at the time of presentation, these are her labs. The lab values in parentheses were labs from 3 months before presentation. So her creatinine went from 1.1 to 5.7. And urine protein creatinine ratio also markedly elevated, a lot of disease markers for lupus, and pancytopenia as well. So we decided to pursue renal biopsy to guide treatment.
All right. Thank you very much for the history, Lily, and for your persistence getting all that set up. So normally at this point, I'd ask for your differential, but in this case, we don't have a diagnostic mystery, but we're just going to see what the manifestations of lupus are at each stage. So I do have her prior biopsies, and I'm going to breeze through the prior biopsies and then focus on the new one. So this was the first kidney biopsy she received, and in this biopsy at low power, we're seeing overall pretty good preservation of the parenchyma. There's minimal tubular atrophy and interstitial fibrosis. These tubules are all nice and pink and back to back. There's just a little bit of chronic injury there. And then if we look closer at the glomeruli, there was focal cellular crescent formation here in this glomerulus, and then a few glomeruli with segmental increased cellularity in the capillary loops, like there and maybe over here. But most of these glomeruli are look reasonably good. So this first biopsy was a focal lupus nephritis, just a small number of crescents and a small amount of chronic injury. Here is the second biopsy where still the overall chronic injury doesn't look terrible, but there we are seeing some areas where these tubules are no longer back to back. And there's a mixture of both active inflammation and chronic injury in these areas. But if we look at the glomeruli, here's just a sampling of some of those glomeruli, and we see multiple glomeruli now with cellular crescents, such as this one here and this one here. And then there's also some segmental scarring here and a wedge-shape attachment between the glomerular tuft and Bowman's capsule, which is a sign of scarring of a previously active lesion. So we have more widespread crescents and a little bit more chronic injury in the glomeruli. And then there was one new finding in this biopsy, which is this structure here, which is maybe a little bit difficult to recognize, but we can see some basement membrane around the cells, which indicates that these are smooth muscle cells. So this is the media of a vessel, probably an artery. And we're seeing that the wall of the artery is kind of overrun by cells that are infiltrating through the intima. And so this is an extraglomerular vessel with vasculitis. I didn't have immunofluorescence images for the previous biopsy, but I do have it for this biopsy, at least for a few of the targets that we stain for IgG, C3, and C1q. And we're seeing strong staining with immunoglobulins and complement. And we're also seeing some widespread extraglomerular deposits in tubular basement membranes and vessels, especially in that C1q image. So all of that is strongly supportive of that clinical history of lupus nephritis. So the second biopsy now upgraded to diffuse lupus nephritis. There were crescents in 50% of the glomeruli, as well as some chronic lesions in the glomeruli as well. And then we also have some new findings of extraglomerular vasculitis and some increasing but kind of patchy interstitial nephritis. Okay, so we'll go into the third biopsy now. And I'll try to slow down a little bit now that we're into the main biopsy that we're discussing for this case. So here's a view of the biopsy at low power. We have a reasonably sized core here, and we're seeing it looks a lot more busy than the last two biopsies. Most of these there's a few areas where the tubules are back to back here, but there are these large broad areas where the tubules are really spaced apart. And at low power, it's hard to tell how much of that is due to chronic inflammation versus, due to chronic scarring versus active inflammation. But it looks like there's a mixture of the two. And we're seeing definitely a lot of areas such as here where the tubules are atrophic. They're shrunken down and have thickened basement membranes. So we'll look at a few of the glomeruli. There are again, like in the last few biopsies, there are some cellular crescents, cellular bordering on fibrocellular here. There's some matrix mixed into this cellular proliferation, and then there's the beginnings of some fibrous adhesion between the glomerular tuft and Bowman's capsule. And then here's a more active or fresh looking cellular crescent. And then there's also some increase in chronic injury. So here's one example of several glomeruli that are almost completely sclerosed. There are some glomeruli where we can see some wrinkling of the basement membranes, indicating some ischemic injury, maybe a little bit of wrinkling in this glomerulus too. We're seeing increased cellularity in some of these capillary loops. And then both of these glomeruli have a little bit of epithelial proliferation, which we're not seeing completely, but so not diagnostic of crescents, but raising some suspicion given the other crescentic lesions that we've seen. In the tubulointerstitial parenchyma, we're seeing more inflammation that we've seen in prior biopsies. So these are some relatively preserved tubules, which are pretty spaced apart by mononuclear inflammatory cells, as well as this pale edema. And then on the left side image, there's atrophic tubules here. So there's a mixture of chronic and active findings for the interstitial inflammation. And then I'm going to go into some of the vessels, and I'm starting with a relatively normal vessel for some comparison before we start looking at vascular abnormalities. So what I want to see in a normal arterial vessel is a nice flat end, a thin intima with a flat endothelium. These endothelial cells are a little bit pooched in and swollen looking, but and then under that we want to have an intact smooth muscle layer making up the media. And in comparison to that one, here's a vessel where we can just barely make out the media that's outlining this vessel, which is how we can identify it as a vessel. Otherwise, it's really severely disrupted by all these cells that are taking over the wall of this vessel. So we again have extraglomerular vasculitis involving an arterial vessel here. And then there are many other vessels that look like the few that I'm showing in these images. We have an intact media layer, but and then here's the elastic lamina that forms the border between the media and the intima. And on the inside of the vessel, there's no apparent lumen. It's completely occluded, largely by this eosinophilic material, which in some areas like this looks like these chunky globs that are all kind of matted together. And then there's also some cells mixed in. And then here's another example where we can make out somewhat discrete chunky deposits in these vessels. So, so vessels like this, we can label as a lupus vasculopathy. This is where those immune deposits are really large and narrow or occlude arterial vessels. And then vessels like this, it's a little bit harder to make out, is it just vasculopathy, or some of these cells might indicate true vasculitis with cells infiltrating the vessel wall. And then I have one more example of a vessel, which is, again, pretty difficult to recognize because of how heavily disrupted it is, but you can make out a little bit of a wall here. And this is just completely filled in with all this eosinophilic material and cells. For immunofluorescence, looked similar to the last biopsy. So I'm just highlighting one image with C1q, which shows us, again, strong deposits in the glomeruli. And then we have an arteriole here, which also has really strong staining that's occluding it. So that corresponds with those vascular lesions I showed you by light microscopy. We're seeing big chunky immune deposits that are narrowing or occluding some of these extraglomerular vessels. So this biopsy shows us a diffuse lupus nephritis again. This time there's not quite as many crescents, but still many crescents. But the chronic injury, the global and segmental sclerosis, is now a much higher percentage of glomeruli. So there's persistent activity and worsening chronicity. And then I showed you the really quite widespread vascular lesions. There was some frank vasculitis, many with vasculopathy, and many that look somewhere in between, where we're seeing a lot of deposits in some cells. And then the interstitial nephritis is more widespread than it was before. So, so the reason I just wanted to show this biopsy, we see lupus nephritis all the time, but these vascular lesions we don't see as often. So I'm just going to briefly talk you through some of the vascular, extraglomerular vascular manifestations of lupus. So what we see commonly are these uncomplicated vascular deposits. This is just immune deposits in the vessels that you can detect by immunofluorescence, but by light microscopy, the vessels look pretty much normal. So we can see this in any class of lupus. This helps us to make the diagnosis of lupus, seeing extraglomerular deposits, but to our knowledge, no clinical consequence of these deposits. I showed you a few examples of lupus vasculopathy where those deposits are really big and chunky, and they're prominent by light microscopy and narrow or often occlude the vessel. There might be some fibrin mixed in with these deposits that's difficult to see, and the intima and the media is kind of dead or replaced here by all these deposits. But in lupus vasculopathy, you shouldn't see a significant inflammatory infiltrate, so it's mostly deposits rather than an inflammatory infiltrate. But we tend to see lupus vasculopathy in more severe disease. I'm going to wrap around here to true extraglomerular vasculitis, which is seen in a pretty small percentage of kidney biopsies from lupus patients. And in these cases, there's not just deposits, but there's also an inflammatory infiltrate and often necrosis of the vessel wall. And these lesions are associated with more severe disease and worse prognosis. And in some instances associated with systemic vasculitis in other organs as well. And then finally, in lupus patients, we can also find thrombotic microangiopathy in extraglomerular vessels. And the distinction here is that we, or the features we look for to identify TMA in these extraglomerular vessels in the acute phase are fibrin thrombi and the extravasation of red blood cell fragments. This image is from another case. We didn't find clear TMA in this patient's biopsies. And for lupus patients with TMA, that can be associated with several factors in the history, such as hypercoagulable states, there's overlap syndrome with systemic sclerosis, or malignant hypertension or complement dysregulation. Okay, so I'll hand it over to Lily to tell us about how the patient did after the biopsy.
Thank you so much. So she was immediately started on pulse steroid while we were kind of deciding on the biopsy and how to treat this. MMF and voclosporin were stopped. And we were discussing obinutuzumab versus CAR T-cell therapy. She unfortunately was not a candidate for CAR T-cell therapy study because of her low GFR. We got the biopsy on the 18th, and dialysis was initiated prior to that to optimize her for that. And after the biopsy came back, we were able to convince the hospital to pay for obinutuzumab. So she got the first dose on the 21st of March. And was subsequently discharged, still on dialysis. And she just got the second dose. It looks like her disease markers may be improving a bit. And I didn't put it on the slide, but her proteinuria is also getting a little better, although still no like significant signs of renal recovery yet. And it looks like she's had maybe some serum sickness like reaction to the obinutuzumab, but otherwise has tolerated the 2 infusions well.
All right, thank you very much, Lily. I think we have a third case, so I'll hand it over to Dr. Smith now. And if there's any questions in the chat, I'll monitor it.
Kelly, do you want me to share, or do you have it?
I've got it up here.
Okay.
Everyone can see it? Okay.
Yes.
So Dr. Carrie Payne, take the lead.
All right. Good morning. So we can kind of go quickly through the clinical stuff here and get to the good part. So this is a 59-year-old man who was referred to nephrology for an elevated serum creatinine and albuminuria. He has a history of hypertension and type 2 diabetes. And sort of the subtext of the question was, is this due to his diabetes or something else? Because it just seemed like perhaps it was something else. So you can see his creatinine over the course of 2020 to 2024 had gone up from 1 to 1.4, and his urine albuminuria had gone up from 400 milligrams per gram in 2021 to 1,700 milligrams in 2024. He'd been feeling well. He had had COVID a few months prior, but otherwise nothing of note. Maybe some myalgias, and this had actually gotten a little bit of a separate workup for myopathy, all of which had been negative. And then, frankly, he didn't really say this to me, but he had mentioned to other providers some foamy urine, perhaps. So really unremarkable. You can go to the next slide there, Kelly. In as far as his past medical history, so he had a 30-year history of hypertension and only a 3-year history of type 2 diabetes, which was well controlled. His most recent A1C was less than 7, hence the question of whether this albuminuria was related to diabetes. No history of microvascular complications. You can go to the next slide. Nothing particularly surprising on medications, what you would expect for someone with hypertension and diabetes. He's a university professor. And on review of systems, the myalgias, which I noted, but nothing else popped up. If we look at his exam, he was a little bit hypertensive, but nothing particularly of note on his physical exam. He did have a normal strength exam in the context of those myalgias. And then we'll see basic labs here. So you can see his creatinine of 1.3. His CBC was normal, LFTs were normal, his serum albumin was 4.4, and then we get down to the urine tests, and he had 3+ glucose in keeping with the fact that he was on an SGLT2 inhibitor, some protein, and so a fairly sort of extensive serologic workup was sent. A little bit of this had been sent preceding me again in the workup for his myalgias, and you'll see that on the next slide. Much of this was negative. So his viral serologies were negative, ANA was negative. The only thing that was positive was that on his SPEP, he had an IgG kappa M spike, and he did have kappa Bence-Jones protein in the urine. And then you can see his kappa free light chains were elevated relative to his lambda, such that his kappa to lambda ratio was about 12. And so a kidney biopsy was performed.
Okay. Due to time, I think we'll go right into the kidney biopsy, but please feel free to add any comments, differentials, or questions into the chat as we go along. So here I'm just showing you a portion of the biopsy. Basically, there were no sclerotic glomeruli, and there was only a little bit of interstitial fibrosis and tubular atrophy, but all of the glomeruli looked abnormal. And here's a picture of 3 of them right here, and you can see that they're diffusely abnormal, and there's a lot of this pale eosinophilic material that's distorting the mesangium and distorting some of the capillary walls as well. Here's a little bit higher magnification. Here's a little nubbin of a glomerulus here. There's really diffuse glomerular abnormalities, and this looks like an infiltrative process. Something eosinophilic is infiltrating and distorting the normal glomerular structures. So massive expansion of the mesangium and capillary walls by this amorphous eosinophilic material. When we look at high power, it doesn't have any obvious substructure. It looks like, people often say it looks like bubble gum. Again, another glomerulus with very similar findings. I'm showing you the Jones stains here. If we look at some of the other stains, we see the meson trichrome. There's really no fusinnophilic qualities for this material. The PAS is really neutral. And then the H&E, so it's this classic eosinophilic material that's infiltrating the glomerular tuft. And so this has all of the features of amyloid and all of the staining properties of amyloid. So we do our Congo red stain to really say, yes, is this amyloid or isn't this amyloid? And the Congo red stain shows that the glomeruli are nice and congophilic. So we see this really pretty orange staining in all of the glomeruli, and it really is restricted largely to the glomeruli. We're not really seeing any staining outside of the glomeruli. And then when we start to polarize this, we can see the nice areas of green birefringence that is pretty much diagnostic of amyloidosis. You can also see areas with a little bit of yellow or orange coloration. And so beautiful histologic evidence of amyloid. We look at our immunofluorescence microscopy to see if we can figure out if we can identify the type of amyloid based on immunofluorescence. And then here, we know that this patient has a monoclonal gammopathy, so there's sort of a bias going into it that we're going to see that. We can see that there's, a little bit more IgG and kappa staining than IgA and lambda, so that's a little bit of a hint. But we're also seeing staining with a lot of other things. And so nothing really sort of stands out as a clear amyloid type. By immunofluorescence, we look at EM, and we can see this infiltrative process. This is really a confirmation of what we had diagnosed based on the light and the immunofluorescence or the light microscopy. Here we can see at higher magnification the obvious fibrils. They're mostly straight and non-branching. And when we measure them, they have an average diameter of a little over 9 nanometers. So everything fits with amyloidosis. And that's our original diagnosis is amyloidosis. It's predominantly involving the glomeruli with really very minimal chronic injury in this instance. And at this point, really to get a clear determination of what the type is, we need to do mass spectrometry. And so here we do mass spectrometry on the patient's sample, and I'm just showing you, the first thing we look at is that the sample is sufficient. And so we find all of these proteins that are associated with amyloid. We have serum amyloid P, ApoE, ApoA4, vitronectin, and clusterin. These are all proteins that we commonly find in amyloid. They're all present. So it looks like we have an adequate sample. And then if we look at what are but the amyloidogenic proteins that are present, and we have a whole series of them, and we see that the dominant one is kappa light chain. And that not only is it dominant, but there's about a 10-fold increase in kappa light chain relative to lambda light chain. So this is really pointing us towards a kappa light chain amyloidosis. So a primary amyloidosis, AL kappa type, it correlates with the patient's IgM kappa spike. And, clearly the consideration that they have an underlying B-cell neoplasm as the cause of the amyloidosis is what's of clinical importance. So what about the immunofluorescence staining? That is a little bit of an issue, right? That we didn't show a really strong kappa light chain staining. And, the thing that we always have to remember is that with a monoclonal immunoglobulin, especially one that's incorporated into this amyloid fibril, that there can be a number of reasons that we don't see staining that really correlates with what we're seeing by mass spectrometry. One would be that maybe the masking of the epitopes due to the incorporation of the light chain into the fibrils is a cause. Another is that oftentimes the amyloid light chains are truncated. And so the antibodies that we use to detect the light chain might not recognize the amyloid form of the light chain. And then also that there's hundreds of variable regions, but there's, essentially only one present in this amyloid fibril. And so maybe that one variable region is just not really well recognized by the reagents that we use by immunofluorescence. So the patient had a workup for monoclonal gammopathy, and due to some insurance reasons and other reasons, he ended up going to the Mayo Clinic, and they did a bone marrow biopsy that demonstrated a plasma cell neoplasm. They also reviewed and did mass spectrometry and repeated mass spectrometry on the kidney biopsy, and they found that this was a fibrinogen A type amyloidosis, and actually detected the glutamine 545 valine variant, which has also been detected before in hereditary forms of fibrinogen type amyloidosis. So a little bit of a surprise and a little bit of a wrench in our diagnosis. So we went back and looked at our case, and we looked at the cases that we also tested that day. When we do the testing, we test a couple of control cases, and then we have our clinical tests. Test 3 is the patient of interest. And in looking at that, we see that there is, more fibrinogen A in the patient's sample, but we also had another sample that had a lot of fibrinogen A in it as well. We went back and looked at all of our cases, and we said, okay, what if we look at all of our cases? And now if we look at all of our cases, we can see that, oh, our patient actually has a high level of fibrinogen A when you look at all of the cases, but there are some rare cases, like the one that we happened to test that very same day, that could have also high levels of fibrinogen A. Well, what do we know about fibrinogen? So fibrinogen is a dimer of trimers. There's an alpha, beta, and gamma chain that are encoded by 3 genes on chromosome 4. The trimers here are linked together by covalent or non-covalent and covalent bonds between the N-terminal regions. And the C-terminal regions of the alpha and beta are located here in this D region. And then there's an unstructured portion of the fibrinogen A or fibrinogen alpha chain that's present here, sort of hanging off in the breeze. This is actually where the amyloid mutations are found, in this region here. So the normal fibrinogen is really a trimer. And so we thought, well, okay, let's look at that. If we look at the other fibrinogen proteins, what do we see? Well, we see that in this one, this test 1 that also had a high level of fibrinogen A, when we look at fibrinogen beta and gamma, we see that it also has high levels of that as well detected, whereas our patient has low levels of this. And so this suggests that, well, this is probably blood or clot, the type of fibrinogen that you see normally, that's a physiologic form of fibrinogen where we're detecting all chains, whereas now our patient here has high levels, but it really consists predominantly of fibrinogen A. And so that's abnormal, and that's then amyloidogenic. And so now if we look at like ratios of fibrinogen A to fibrinogen B or fibrinogen gamma or beta, we see that there's a low level of fibrinogen A present in clots where it's the ratio is much higher in the amyloid protein. So so if we went back and reviewed our data now is also very, very consistent with an amyloid that's due to fibrinogen A protein or fibrinogen alpha. You know, in this case here for us was really sort of the perfect storm. So we encountered the rare type of hereditary amyloidosis. This is actually the first case that I think we've seen at University of Washington. We've never typed fibrinogen alpha previously in our lab, and so we really were not prepared to detect this readily. And not only that, but this patient also had a monoclonal gammopathy. And that further complicated our ability to really accurately type this patient's amyloid. So the monoclonal IgG kappa is something that we also have to take of note because monoclonal proteins can be detected at elevated levels within tissues in the absence of amyloid formation. So they can be a cause of a false positive test. So to mitigate this, what are we doing to correct it? We're adding really a quantitative analysis for fibrinogen A and other rare amyloidogenic proteins into our pipeline. We're also adding additional steps to verify, such as detection of the variant mutations, identification of unusual structural features. So another quality then of the form of fibrinogen alpha is that you only find the truncated form of the protein in the amyloid, not the full-length protein as you'd find normally in physiologic forms. And then other unique qualities, such as looking at the ratio of the alpha to the gamma or the alpha to the beta chains. So what about fibrinogen alpha chain amyloidosis? It's the most common form of hereditary renal amyloidosis in the US. That being said, it's very rarely encountered. There's several variants that have been identified. They have variable penetrance. Most of the variants are localized to a discrete region in the C-terminal half of the protein. There's been 15 variants so far reported. The variants actually are not found in serum. It's hypothesized that these are consumed more rapidly, so that they turn over more rapidly, so you can't really identify them easily within the patient's serum. And about 50% of the patients, as this patient's, lack a family history of renal disease or amyloidosis. The average age of diagnosis is 46. Presentation is usually proteinuria, oftentimes subnephrotic and renal insufficiency. Progression to end-stage disease is common, and after a diagnosis, over half of the patients progress to end-stage disease within 5 years. The systemic amyloidosis can involve other organs, and heart, liver, and spleen are some of the more common sites. And treatment is really, fixing the end-stage disease. So there's no way to prevent, I think, the disease from leading to end-stage disease, but you use dialysis or transplantation to treat it. Misdiagnosis is not uncommon. So 15% of the cases are misdiagnosed as AL amyloidosis. And as I indicated, presence of a monoclonal gammopathy can complicate that and lead to false positives. So, false negatives. So like a false diagnosis of a misdiagnosis of AL amyloidosis. There can also be false positives. So it's fibrinogen A is common. It's a common serum protein. It's present in blood clots. So it's important to be able to differentiate an amyloidogenic fibrinogen alpha from the normal physiological forms. So identifying whether it has an amyloidogenic variant, identifying whether or not there's more alpha versus gamma and beta that really would fit with this as an amyloid, not a normal physiologic form of fibrinogen, and then the truncated protein as well. I'll turn it back to
Yeah. So I know we're over, but so yeah, this patient was diagnosed not only with the fibrinogen A type amyloid, but also with a high risk IgG kappa multiple myeloma. He was treated with 6 cycles of daratumumab, Revlimid, Velcade, dexamethasone, and he's currently in workup for autologous peripheral blood stem cell transplant. You know, we don't anticipate that will treat his kidney disease, right? It won't. There's not a treatment for the amyloid independent of a liver transplant, which is not in his near future, obviously. His creatinine stable at around 1.4, and his proteinuria is about the same right now. So just conservative management, blood pressure control, SGLT2 inhibitor, et cetera.
Okay. Any questions? And I guess we can.
Simple comment from Sarah in the chat. I'm very impressed with this interesting and unique case. Any other questions, comments? Well, as others mentioned, I know we're a bit over time today. Thank you, everyone, for tuning in to these to our first talk in these very interesting cases from the biology conference.